So what we're going to look at today are, I put in some objectives, and it looks like a lot, but we're not going to spend a lot of time on each one of the topics. Just going to sort of cover them enough so that you understand what we're talking about. So we're going to review the steps in surveillance design, and there's a bunch of those steps. One is selecting the methodology. One is determining which population you're going to look at. Then what events are you going to look at? And then we're going to discuss, again, why you use rates versus case counts, why one is better than the other. Then we're talking about the time period over which surveillance will be done, because it depends on what kind of surveillance you're going to do. And then we're going to identify the criteria and talk about data elements that should be collected for different types of surveillance, determine the methods for collection and management, and how you might analyze it, and then methods of data collection. Oh, it says it twice. I'll have to get rid of that before we actually put this on YouTube. Determine how diseases are chosen for surveillance is the last part. So, to select surveillance methodology, targeted versus whole house. You've heard this before. Once upon a time, I've heard that long-term care did whole house surveillance. And from what I understand, that was very labor intensive. So right now, you're practicing targeted surveillance, and it's more focused. Some of the targeted surveillance activities could include surveillance for specific organisms, such as if you're doing surveillance specifically for MRSA. You might be doing infections related to medical devices, such as looking at UTIs with catheters. Or you might be doing infections with a specific system of the body, like you do, like I've seen you do, respiratory infections or skin infections. Or you might be doing organisms of significance, such as COVID-19, which has started in the last year and a half, which was new to you guys, because that was different than just doing surveillance of the respiratory infections. So to assess and define your population under study, you need to determine who is at risk for the infection or the colonization of the microbe. Sometimes you're just looking at to see who's colonized with it, and that would be for MRSA. Determine which population we're caring for, the type of the healthcare services provided, the type and number of invasive procedures you did, such as how many times you catheterized the person, and the general conditions and risks for the population at risk. Why is your population more at risk for certain types of issues? Now, you may not be too worried about MRSA colonization in a long-term care facility, but if you got a colonization of a carbapenemase-producing Enterobacteriaceae, which is a CPE, which you might have heard of before, that would be more concerning because your population is more vulnerable, and that particular organisms, that group of organisms is usually considered more harmful. So for a vulnerable population, it would be more concerning. So that would be why you define that you should be doing surveillance on that. Does anyone have any questions thus far? I can't see the chat, so Carol, if you see anything there, please let me know.
Will do.
Okay, no questions. So which events will be monitored? This is one of the most important steps. There's usually two reasons to do surveillance. You either want to do outcome surveillance or process surveillance. Outcome surveillance has to do with infection rates. That's an example. It's the end point, what you're looking for at the end of your surveillance. Whereas process surveillance is you're monitoring things that could influence the outcome, such as you might have all of a sudden a lot of one specific type of infection, let's say UTIs or respiratory infections. So that's your outcome data, but you're wondering why you're all of a sudden having an increase of these rates. So you could be involved in hand hygiene auditing, which is a process surveillance to determine whether or not hand hygiene has dipped in your facility, and that may be one of the reasons why the infection rates are going up. So they usually complement each other. You're doing process measure surveillance to determine whether or not it's impacting outcome surveillance data. So the outcome data focuses on the characteristics of the patient, their care, any interventions that were used, and how this impacted the outcome. When I say ARO, that means antimicrobial resistant organisms, and an example of that is MRSA. Process surveillance focuses on how things happen along the patient care pathway, not what happens at the end. So the indicators that could be chosen to monitor are usually high volume or high risk. So the data that could be collected are the setting, and your setting would be a long-term care or a PCH setting. The people that would be included, so that would be the population that's at risk, and sometimes like this might include staff, such as your COVID surveillance. The acuity of care. Sometimes you have wards or units that have patients that are more at risk than others. And then risk factors for that specific outcome. So what makes a person at risk for that infection? That's what you need to collect as well, because if you have a bunch of people who are getting a specific infection, maybe it's because they have all one specific risk factor. It's important to know how available the data might be, because if the cases are very rare or the charts don't have adequate data that's documented, it would be very difficult to conduct the surveillance on this type of issue. So documentation greatly impacts the ability of surveillance to find the information that's required. So that's why it's also important to encourage your staff to document what they see when they're actually seeing infections. The ability to make interventions based on the data elements collected. That's if you can't make an intervention to actually change the outcome, or if the intervention is out of your power or control, then it isn't actually useful to actually do surveillance on that area, because you don't have the interventions to make change. So that's why it's important to note the ability to make interventions before you start doing surveillance. Now, also Accreditation Canada and Manitoba Health have reporting expectations, and you have to meet those. And then your specific organizational objectives or your particular facility might have specific reasons they want one type of surveillance to be done versus another. Now, case counts versus rates. It's not best to use case counts when sharing numbers. This is because case counts don't provide the information about the population at risk. Case counts can't be generalized, so the rates should be used instead so that comparisons can be made not only between your different units, but eventually to other PCHs within the region. Hopefully we can get to that state once we're actually sharing data a little bit better than what I know have been thus far. The specific importance of ARO rates. This is specifically important for ARO rates. This is because we can compare then between units of different sizes and PCHs of different sizes. Because I know at least in some facilities, you have smaller units of, let's say, 20 or 18 people, and then you might have a larger unit that has up to 30. You can't compare case counts in both of those places because they're just too different a size. But if you compared rates, then you could compare the two different areas so that it's comparing apples and oranges, or apples and apples, not apples and oranges. So prior to starting a surveillance program, you should plan how you want to describe your final results and which rates you're going to use. So you can capture the numerator and the denominator. The case counts is your numerator and your denominator are your patient days. I know I threw a lot of information at you right now. So does anyone have any questions about what I've just talked about? Okay. Time period for surveillance. Now, this might not make sense to you if you've been doing routine surveillance for a long time and you've always been doing it the same way. But sometimes when you do surveillance on a rare event, you have to collect your data over a longer period of time. However, if you're doing surveillance on something that happens much more frequently, you can do surveillance in a shorter period of time, such as a month or a week. Whereas for the rare event, you might be looking at a quarter, like 3 months or 6 months at a time, sometimes even a year to determine what your rates are. Things like an enteric outbreak, you're going to be wanting to follow that rather quickly, so you'd be doing it a much smaller period of time than, let's say, a CPE rates, because they are relatively rare in your facilities thus far. Also, you need to determine if you're going to just do a pilot, which is short term, or let's say you're going to do a point prevalence study. You're only going to look at things 1 week out of a month. These are all decisions you need to determine as to how you're going to do your surveillance. And sometimes these decisions are made for you, and this is just explaining why they are made the way they are. So, case surveillance criteria. Case definitions need to remain consistent over time. And this is really important because it's otherwise difficult to make decisions about whether or not things are changing. Because if you see change in your case counts and your rates, and you're changing definitions at the same time, it might have more to do with the change in definition than it has to do with the change happening in your population. As well, if there's national case definitions that have been developed, these need to be used. If one changes case definitions, and what you're collecting will actually change. And so sometimes this does need to happen, such as if you're using very old criteria and you need to adapt to the new national case definitions, you are changing your case definitions. And if you do that and you send out reports, you just need to ensure that you reflect this change in your report so those reading it can understand why there might be a difference at that point in time. Oh, and the second bullet here is really important. The criteria used for making a diagnosis and treatment is quite different sometimes than the surveillance criteria. For a doctor to determine whether or not a respiratory infection is happening, he may just look at a person and determine that based on the presentation that the patient is showing. However, a surveillance case definition has a number of bullets and points that have to be met in order for it to meet that case definition. And if not all the points have been hit, and only some of them have been met, then you don't meet the surveillance case definition, even if the doctor has diagnosed that patient with that condition. Sometimes this is difficult, such as a UTI, because sometimes the doctor might be treating it for a UTI even though it doesn't meet case definition. So this is something you have to keep in the back of your mind, that you have to actually be using your case definitions when you do surveillance. The data elements to be collected. Limit it to only those you need to understand the situation and provide information about where interventions might be possible. it's never a good idea to collect data for the sake of collecting data in hopes that one day we could actually use it. It's better for that kind of data collection to be used for research studies, and instead what the data elements that are often recommended for data collection are the patient's name, their sex or gender, their age or date of birth, preferably date of birth because it's more definitive, their medical number, and depending on where you are, that might be a registration number for your facility, or it might be the FIN. FINs are usually used if you're going to describe a patient who might be moving across facilities. Unit, room, and bed, the physician name and service, the admission date, the date when the specimen was positive. Sometimes you also take the date that the specimen was taken. The date of isolation if it's required for that specific organism or that specific condition. The place on the body where the specimen was taken, such as, let's say, nares for MRSA, or a wound for MRSA, or a UTI. You just mentioned that it came from the urine, or a catheter, or stool for C. difficile. Organism isolated, that sometimes is important because some of your definitions will require an organism to be found for it to meet the criteria. If it's an infection or a colonization, sometimes for wounds, you can have infection definitions that have to be met. And if all the criteria are not met for an infection definition, then that wound may be colonized with that microorganism. Date of discharge, transfer, or death is another data field you might want to collect. And if you're doing something for device surveillance, such as catheters, you might want to also collect the type of device used, the date that it was inserted, the duration of use, or the date that it was removed, the body site, of course, if it's catheters, you know where that is, and type of device used, just in case you're changing types in between and one of them seems to be more prone to infection. Any questions thus far? The data elements or data fields that we just talked about should be part of your line list that you're collecting on your patients, or part of your data collection sheets that you use when you're collecting your paper data collection. I have seen some of them, so I have an idea how some of them are being collected. But I certainly haven't seen what's going on in most of the PCHs yet.
Myrna, no questions in the chat, but I did put a comment just on the minimum, like the data collection piece, and your comments about not collecting just in case. And I just wanted to flag from a privacy perspective also to remind folks that's one of the premises, the key principles of PIA, right, is collect only the minimum need to know to do your job, which also pertains to surveillance too. So 2 reasons to be sure what you need.
Yes, exactly.
Thanks.
Also PIA is very important and probably the #1 important rule of thumb with that, but also don't want to waste your time collecting data that isn't necessary. Okay, methods of data analysis. You need to plan for analysis before you collect the data. How do you want to work with your rates? If you need to have rates, then you need to have a numerator and a denominator. If the cases are rare and you're attempting to find outbreaks, you might use different stats. And it might not even be complicated stats. It might just be percentages. And again, rates should be used rather than case counts so you can make comparisons. So prospective data collection, if timely, can assist much better with finding outbreaks, and it is the best way to find outbreaks. It's rather distressing to find out you had an outbreak 3 months ago because that's how long it takes you to get around to collecting the data from 3 months ago. I can't say that that hasn't happened in acute care, because it has. And I would hope that it's not happening in long-term care, because you guys are better acquainted with what's going on in your facilities. But it does have its drawbacks. Prospective audits can be useful, but then you have to go onto the units to find the charts or find a staff who have the information that you need. And the charting may not still be complete at the time when you're actually auditing. Retrospective auditing is when you go back a certain amount of time to do your surveillance. And the records might be more complete. However, they're quite delayed usually, and then interventions that might be required are also delayed. So if you do have an outbreak, then all of the interventions you could have used for your outbreak are maybe beyond the point when they would have been most useful, and your outbreak is beyond where you wanted it to be, where it was, let's say, 2 or 3 cases, and it's now 8 or 9 cases. Databases or Excel spreadsheets should be used to try and collect your data rather than just paper forms, because then you can do some analysis from the line lists directly. I'm not sure what's happening in each of the PCHs, and that's something that I can learn from Carol as time goes on. And again, data quality in equals data quality out. If you have issues with the quality of the information you have in your system, then you are going to have quality issues with the data that can come out of the system. Always double check the values that you are entering to see if something seems unexpected. And if it does seem unexpected, maybe you need to double check it. The greater number of transcriptions that are required for data to finally get into an analysis stage will mean there are likely more errors that can creep into the results. If the data can be more accurately entered directly into an electronic tool, such as a spreadsheet, then maybe fewer errors could result. But in this scenario, there's also not a paper backup copy. So in that case, then, if you need to review the data, you have to go all the way back to the chart and check it again, versus looking at a data collection sheet, which would just have the data already collected for you. So there's pros and cons to data transcription, which need to be weighed. And if data collection onto paper is chosen, then extra care must be taken, both at both times of transcription, from the chart to the paper, and then from the paper to the spreadsheet. So you know, based on what I just said, that there are pros and cons to using paper or using a spreadsheet. And lastly, what we're going to discuss today is how infectious diseases are chosen for surveillance. First of all, they look at the frequency. This is what Manitoba Health did when they were choosing the diseases that you needed to do surveillance for the Public Health Act. They look at incidence and prevalence of these diseases. And I actually was quite privileged to be part of the working group that chose the list that they are currently using. Severity. How severe is the disease? Does it have a high mortality rate? Does it have a high case fatality rate, such as if you get this disease, you will more likely die? What is the disability rate? That the cases actually have more morbidity than if you don't get the case, if you don't get the illness. Cost. How much does this illness cost the system? Preventability. How successful could a health response prevent this illness? Communicability. How contagious is this disease? And public interest. And public interest does actually fall into how they make decisions about what diseases are chosen for surveillance at the provincial level, because some diseases which might not have a lot of cases in our province, or at least a lower level of cases in our province, but have a very high level of public interest, will still be followed. These were the aspects of the infectious diseases that were reviewed prior to the Public Health Act being developed. And these diseases will change over time. And those who are responsible for reporting will also change over time. Sometimes in the past, it was actually up to the healthcare providers to do the reporting. And now it's sometimes the healthcare provider and sometimes the lab. So it doesn't always stay that consistent. It depends on how easy it is for the reporting to be done by different individuals or different organizations. So some diseases that you might recognize that are on the public health list are botulism, pertussis, rubella, and tuberculosis. And there are many others, but the likelihood of them showing up in personal care homes is pretty low. So I wasn't going to worry too much about them. But if you wanted to know which diseases are actually required for person-to-person reporting, such as you have to report it, not just the lab, you can always contact me. But also one of the important things that's required in the Public Health Act is that outbreaks need to be reported to Manitoba Health. And that is either done through a SIDFI report, which I'm sure you guys are aware of, or if it isn't a respiratory or an enteric disease, such as, let's say, an MRSA outbreak that's going on in your organization or a CPE outbreak that's going on one of your units, that would be done using a different form that Manitoba Health has for reporting outbreaks.